I'm delighted to introduce Jang Ho Yoon, who is the Associate Professor in Health Policy. Health Management Policy Program is co-sponsoring this seminar, so take it away, Jang Ho.
Hello, everybody. It is a great pleasure to introduce my longtime friend and colleague, Dr. Tim Bruckner. Tim is an associate professor of public health and co-director of the Center for Population Inequality and Policy at the University of California, Irvine. He also running the doctoral program in public health there. He's a population health scholar with training in epidemiology and health policy from UC Berkeley. One of his main research area relevant to today's talk is the determinants of health seeking for mental disorder. In past work, he has examined how upstream social determinants such as public mental health policy and other macro-level shocks such as economic downturns affect psychiatric emergencies in involuntary homes. With that being said, I will give you Dr. Bruckner. Please give him a warm welcome.
Thank you, Jung Ho. I really appreciate it, and thank you again for inviting me. I'm really excited to be here. So I wanted to motivate this talk a little bit by mentioning that worldwide, depression ranks second as the leading cause of disability. And in general, I think we under-investigate causes of mental disorder and causes of mental health help seeking. The good news for health services researchers and epidemiologists is that there's a lot of variation across place and time in help seeking for mental health and in the incidence of mental disorder. Much of my work as a population health scholar uses natural experiments, if you will. So I look at plausibly external factors that could influence the determinants of mental health and help seeking for mental disorder. Some of them involve terrorist attacks. Others, hopefully this will never be your situation, doctoral students, where you have your Ph.D., published 3 papers, have done a postdoc, and are still looking for a job. But I've also looked at the Great Recessions and economic downturns. And today I'm going to talk about something that's maybe more positive, so I don't just study negative shocks, but something that in a system level has really had a profound influence on mental health help seeking in the United States, and that's the proliferation of community health centers in the US. So to motivate this too, if we look at suicide is highly publicized as mortality increasing over the last decade, but also help seeking for psychiatric care is also going up. So if you plotted over from 2006 to 2013, the emergency department visits for a psychiatric reason, they've increased about 54% in the United States. And we don't necessarily think that this rise is totally due to the epidemiologic increase in psychiatric disorder. We think it often has to do with help seeking going up. In particular, the lowest income quartile in the US has the largest share of help seeking in the emergency department relative to higher income groups. And we think that an increased reliance of lower income populations on the safety net represents this increase. There's also a concern that the reliance on the safety net for psychiatric care in the emergency department often occurs if there's even non-urgent conditions. So that creates a problem from the health system perspective, because although there are great emergency department physicians and great emergency rooms, they don't often provide as optimal continual care or continuity of care for persons with mental disorder as would non-urgent care settings. And also, after the discharge, it's very hard for those with a mental disorder to then make sure that they're being followed up. There's also this crowding out issue where individuals with non-urgent conditions who seek care in the ED might make it harder for those with urgent conditions to quickly get care, right? And then there's also the cost angle for those of you that are health economists. So this creates a variety of issues. And then we think, well, wouldn't it be wonderful if those low-income populations that might rely on the emergency department instead had some continuity of care in the primary care setting? So would it be the case that if we could increase mental health care in the primary setting, it might reduce the demand on the psychiatric care in the ED? Sounds wonderful, but do we have evidence for this potential substitution? Can we really transition this population to the primary care setting? The evidence is mixed. I'd say some of the best evidence actually doesn't support substitution. So this was in Taubman's paper published in Science, so obviously it was a big deal, not just for health services researchers, but for the scientific field overall, in which expansion in Medicaid, so this was in a kind of a lottery system, so we think of it really as a random assignment for those that received extra Medicaid, they showed an increase not only in primary care visits, but also in emergency department visits. So you could think of it like a buffet table. Maybe you're not so hungry, but you're maybe timid to go to the table, but then you have the appetizer, and well, now that you're at the table and you feel comfortable with the entire buffet, you might navigate through all aspects of the healthcare system as you would through that buffet. That's my analogy, not Taubman's. Just the idea that maybe getting used to one modality of healthcare then expands. I would mention, though, that this result didn't focus only on psychiatric care. This was more of a general finding. So it really remains unclear if we could have that substitution occur, but within that context enters community health centers. So these actually have proliferated well before the Obama administration. They are federally funded, predominantly serve Medicaid population and the uninsured, but there's also some private insurance individuals that they serve. They focus geographically on medically underserved areas, which disproportionately have lower income and ethnic minority underserved populations that are there. And they serve all patients regardless of the patient's ability to pay. Okay, so that's very important. You can think of it on a sliding scale, but essentially free to the patient. And it's funded at around $5 billion a year, so it's a non-trivial investment by the federal government. And actually that number is going up, so now they serve around 28 million Americans. So it's actually a large share of Americans that seek care through these FQHCs. They're also called community health centers, so I'll call them CHCs for the talk. Over a 10-year period from 2006 to 2015, CHCs grew rapidly. Patient volume rose by over 70%. And so this was from 18 million to 28 million. And again, the majority of those seeking care in CHCs have Medicaid as their source of insurance, and then another 38% of no health insurance. And again, a lot of the growth in CHCs predates the Obama administration, so this was widely hailed by the Bush administration also as a positive increase in primary care. And a lot of the data that I'm going to talk about precedes the ACA legislation, and in some ways it's because of the data limitations that I have what's available, but also precludes some attribution of any result to the change in the ACA. Here's another plot that tells you about the growth in community health centers over time. The line here is 0. This is kind of, you think of it as like percent. So this is 10% growth and 20% growth annually. So there was basically no year from 2008 to 2015 that didn't see an increase in CHCs. And the average increase in CHCs for overall patients was around 8%. But what I want to point out with this plot is that the rate of growth in mental health services outpaced average growth. So put another way, a larger share of the patients seen at CHCs, which were all growing, was in mental health services. So we have a rapid expansion of mental health services provided within a rapidly growing CHC context. So are they effective? If you listen to political proclamations, most people say CHCs are widely effective because they serve underserved communities. And that's basically where it ends. Or there's a cross-sectional analysis that says individuals who report getting care at CHCs spend less money overall in 1 year. I would say the policy question that's more important, though, is When we grew these CHCs, did we see a reduction in maybe the psychiatric ED volume or the reduction in the overall incidence of severe disorder or in more routine help seeking? Because we continue to expand these CHCs without much attention to their effectiveness. Forget about cost, but just even in terms of the health effectiveness. So what I'm going to talk about is give you kind of 3 papers in one. So please bear with me in terms of the speed with which I go through these, but the good news is they're all published. Actually, the last one isn't published yet, but I can obviously give you references later. But I want to talk about 3 parts of assessing effectiveness of CHCs. The first is really overall. So overall in the population, does psychiatric ED visits, which I'll use as a measure of kind of the success of a system of care, do those decline when CHCs expand? So that's kind of aim 1. Aim 2 is, well, if these CHCs are argued to focus on medically underserved areas and disadvantaged communities, is there kind of an ethnic disparity reduction? So have we expanded mental health care, for example, among African Americans faster than for whites, which might have narrowed the disparity in the psychiatric ED help seeking? And I'm going to focus on children here because that shows the biggest disparity in ED use across these race ethnicities. And then I will conclude by looking at really taking a drilled down look into suicide. That is clearly a priority by NIMH, so any of you that are writing grants to NIMH probably are including suicide into it. And so I want to really drill down to see if suicidal ideation and self-harm in the ED might have also responded to increases in community health centers. Okay, so for the aggregate test, we use the SED data, so it's the statewide emergency department database, which is sponsored by HCUP, and not all states report all the emergency department data by year, but we have 9 states that have consistent definitions over a panel of 5 years, and they're indicated in red here. So we have representation in the West, in the South, in mid-Atlantic states, and also in New England. And some of those states are very populous, like California, Florida, New York. And we are looking over time, and there's county information identified in the SED data, and diagnosis and race ethnicity and age of the visit, of the person that visited. And again, this 2006 to 2011 period underwent rapid CHC growth. I mentioned about the statewide emergency department database. For the states that reported to HCUP, virtually 100% reporting of emergency department visits. And a psychiatric ED encounter was classified if any of the diagnostic codes included a psychiatric diagnosis that was agreed upon by the classification system coding by the federal government. And the outcome, in terms of whether overall primary care expansion was successful, is looking at the overall incidence of psychiatric ED visits per population. So we include census information on the population counts at risk to arrive at appropriate rates. And in terms of getting information on the health centers, that's publicly available information from a Freedom of Information Act. And so you get information on the mental health services provided at CHCs, their location, their visits per patient, the conditions that they were seen with, and the age groups that were seen at the CHCs. And the CHCs, as a condition of receiving funding, have to give these reports. So we think that at least they're reliably reported. Maybe, I don't know how accurate they are, but they, as a condition of funding, do get sent in to the federal government. So we don't have missing data there. And we'll examine 3 measures that come from CHC growth. One is this notion of total patients per population. And this is the idea that perhaps it is the case that mental health care is increasingly provided by primary care physicians. And so maybe overall primary care visits are kind of measuring this maybe depression screening. We'll also look at the mental health patients seen at CHCs, if that exposure could reduce overall psychiatric ED demand. And other kind of proxies that are control variables for system-wide expansion of services. So we'll look at overall psychiatric beds, and other controls for health system characteristics. And we'll perform a county fixed effects model, given that counties vary dramatically in terms of the populations they serve and the health-seeking behaviors. So we essentially control for the county fixed effect, and we also have a year fixed effect, so that we essentially absorb a lot of those trends over time in growth in psychiatric ED visits and health centers. So really the fixed effect framework capitalizes on year-to-year changes in psychiatric ED visits as a function of year-to-year changes in primary care visits at CHCs in that county year. Okay? Here's a plot of overall psychiatric ED visits, so the dependent variable aggregated across counties. As I kind of alluded to earlier in the talk, we have a huge rise in overall psychiatric ED visits for the 143 counties in the 9 states. And this table, I don't really expect you to focus on all these numbers. Really, the key point is in all of these counties, there's a lot of variation. So the standard deviation of psychiatric ED visits, community health center patients, poverty, CHCs serve a diverse set of counties. So the standard deviation implies to the analyst, we have a lot of variation to explain, right? So that's always nice. And in general, though, as we expected, CHC patients are also expanding in these 143 counties. Again, for the fixed effects, I removed the trends, so this is more just descriptive for you to see how rapidly they've expanded. All right, so the first main result is in looking at overall growth in the community health center total patients. And here we see an inverse relation. So in county years in which overall CHC patients expand their volume, we see a reduction in psychiatric ED visits. And this controls for a variety of other covariates. And then looking at mental health patients, we actually see no relation in aggregate. Okay. So how do we interpret this? Well, this wasn't necessarily my prior. I thought that if you expand mental health patients, maybe that's the better measure. Other psychologists and experts in the clinic said, well, Tim, what might be happening is that a lot of the mental health care provided at these CHCs is not done by specialists. It's done by primary care providers who are more and more comfortable doing depression screening and prescribing of antidepressants, for example. So it might be the case that as we're transitioning and becoming more comfortable with primary care providers providing mental health care, this might be one of the explanations. So that, admittedly, it's a post hoc explanation that demands further inquiry, but that's the interpretation of the aggregate result. Okay. All right, so now I'm going to move to part 2, disparity reduction. African American children rely more on the emergency department for psychiatric care than do white children. It's kind of paradoxical because in general, help seeking for African Americans for mental health is much lower than for whites. So they seek care for mental health less, but when they do, it's in the ED. Okay? And so there's this question about whether these really focused geographic efforts to increase CHCs, could that have narrowed the disparity in psychiatric ED care among youth? Put another way, do African American youths benefit more than other race ethnicities after CHC expansion? Data set, similar setup. The key difference here is now I'm using a logistic regression in which the outcome is race. So now I'm predicting a psychiatric ED visit from an African American, that would be like the outcome versus white, right? So it's kind of a rate ratio of the rates of ED visit by race. And again, it's pretty much a counting year fixed effect control setup. with other visit level controls that the aggregate test could not have done. So now I have granular information on every visit, right? So instead of 143 counties times 6 years, I have a couple million children. So that's important to think about when we're interpreting the results. You'll see a lot of stars of significance, but the question really is, how big is the result, right? So we're thinking about scale more than always significance. And here it's a descriptive plot about psychiatric ED visits to really underscore my point. African American rates of ED help seeking are higher than for whites over the test period. And here are the main results. These are 3 separate regressions, so I'm putting in 3 separate exposure variables and 3 separate models. This is a summary of those, and that's why I'm not giving you specific coefficients for the covariates, because they would change with each specific model. But the general direction of the covariates is consistent across the 3 models. Right? So what do we found? What do we find? First, overall mental health visits that expand at CHCs actually correspond with more psychiatric ED visits. So the buffet table, maybe. And then, but if we look at overall visits per patient, which might be perhaps an indicator of continuity of care, we see the inverse. Health centers that more intensively treat each mental health patient correspond with a reduced likelihood of ED visits among African Americans. Okay? And then total visits, no relation. These covariates I'm happy to talk about in the Q&A, but they behave in predicted ways. How do we interpret this? Well, in terms of scale, in the county studied, 1 standard deviation increase in mental health patients, visits per patient have about 4,200 fewer psychiatric ED visits for African American youth. And it could be the case that this health center expansion overall might have led to access of mental health care for more African Americans that compelled them to use both primary care and emergency care. But if we think of continuity, visits per patient could have maybe indicated quality of care or continuity in ways that better engaged minority patients and might have reduced the risk of psychiatric ED help seeking. Okay? All right, and part 3. So now let's get to suicide. Okay, so suicide's obviously in the news a lot. The overall mortality associated with suicide over the last 15 years has gradually increased. Gets a lot of attention. The case in the emergency department is actually very similar. So emergency department visits for suicidal ideation and self-harm closely follow the mortality trends. You can basically draw a line here in terms of the increase. So this is an alarmingly large increase. What is this? Almost 3-fold increase risk in emergency department visits for suicidal ideation and self-harm over a 10-year period. Okay. And interestingly, in the suicide case, for mortality and for ED help seeking, whites tend to seek more care for these conditions and also are more likely to die of suicide. And so I will focus on race-specific analyses for whites and African Americans separately because of their distinct help seeking. I'll aggregate across all age groups. And here, like in the first study, it's more of a county year fixed effect approach. The outcome is an aggregate level incidence of suicide and self-harm ED visits by race. And the good news with this, I have a little bit more data sample through a data supplement from NIMH, so I have a larger panel of counties to examine over time. So this is 1,400 county years over 9 states across 10 years. And I'll just jump right to the results because the data are familiar. So the top two, again, these are separate regressions, but it's focusing on whites first. Overall, in terms of visits per population for mental health, there's no relation. But potentially an indicator of continuity of care, visits per mental health patient at CHCs correspond with a reduced risk of suicide, ideation, and self-harm ED visits for whites. How about for African Americans? Nothing. So it looks as if CHC expansion for the outcome of suicides appears to have benefited whites more than African Americans. Why would that be the case? Well, I mentioned earlier that help seeking among whites is more common in mental health than for African Americans. What's interesting in the CHC expansion story, which hasn't really been publicized much, is that counties that have a higher fraction white are counties that have expanded their mental health services faster. Another way of putting that is that there might be something about the county level demand for mental health services that CHC growth is responding to, right? And so even if CHC, one of their goals was thinking of a disparity reduction strategy, it might also be responding to demand. And more of that mental health demand might be coming from whites. So this is kind of, I think, an interesting dynamic that would compel us, I think, as health scholars to think about what about help seeking for mental health among African Americans could be improved? What are some of the barriers in that population that might make it very challenging for them to access CHCs? So, what's the overall take home from these three empirical pieces? If we say, are CHCs effective? I'd say, well, it depends. Are you thinking about efficiency in terms of maximizing or minimizing overall psychiatric ED visits? Are we thinking about equity in terms of disparity reduction? I'd say from the efficiency perspective, we have modest effects which show a benefit of CHC growth on reduced psychiatric ED visits, but we probably can rule out alarmingly large benefits, counter to political proclamations that they're super effective, okay? And also, I would say overall, though we want to think about maybe what aspects of CHCs are cost effective, because psychiatric ED visits are very expensive. So I haven't really put any financing aspect into this. I would love to have collaborators if you would be thinking about converting this to cost effectiveness or comparative effectiveness. I would argue that some of these effects that we discovered probably would fit the bill here and be effective. But I think one of the key questions that really these data cannot answer is thinking about what's the quality of care delivered at these health centers. Do they actually integrate behavioral care into primary care? This plot, or this figure is complex because, well, the integration of primary and behavioral care is complex. So this gives you some of the issues surrounding how we would think about taking patients that might have other comorbidities and treat them effectively in a primary care setting, and being really attentive to depression screening and continuity of care for severe mental illness at CHCs. So, in terms of next steps, I would say we want to have a better understanding of kind of the level of care integration at CHCs. We want to think about maybe some CHCs are exemplary and others might need a lot of areas of improvement. Starting in 2014, the Uniform Data System requires CHCs to report on the quality of mental health care provided. It's this like depression screener score. So the general idea is, have you screened over 70% of all patients that walk in for depression? And if you have, you get a gold star. You're a good CHC, right? So they have all these other measures for diabetes and cardiovascular disease if you take blood pressure, but they don't have a measure for mental health until the depression screener score comes on in 2014. So that's something maybe we look at in terms of looking at the high-performing CHCs, if we would consider them that. And then, given this finding about mental health visits per patient, and maybe this indicator of continuity of care, we would also want to unpack if these CHCs really are effective in kind of handing off mental health patients to other care modalities. Something that is a little bit outside of the CHC realm, but Jang Ho and I have a lot of interest in this, is kind of how EDs are also maybe indicators of the overall system's failures. So if you do ED boarding, right, so how long does somebody have to wait in the ED before they actually get care? Or something I'm working on with my student, what about court-ordered and police-initiated emergency department visits, which in California, sometimes they take the form of involuntary civil commitments. So this is the 5150 police code in California. I don't know if that's an issue in Oregon with homeless population that might also have severe mental illness. Something that I think is really interesting and important. And then also more just from a population perspective, thinking about other kind of policies and other kind of external antecedents of help seeking for psychiatric care in the ED are very interesting to me. I'm working on the Great Recession right now with another student. And again, I would completely welcome collaborators, because the beauty of Oregon is that they have so many experiments in their society, in their state, right? You have, you're really at the forefront in terms of Medicaid expansion and other policies. So, in that whole notion of the experimentalist society, you have a petri dish that many other states do not. So if any of this interests you and you would be interested in collaborating, please get in touch. I'd like to acknowledge our funders from NIMH, as well as colleagues. Of course, the best one is in the back there, John Harris. And also Lonnie Snowden at UC Berkeley, Bharath Chakravarti at UCI, and my stellar doctoral students, of whom one is on the job market right now. So thank you very much for your attention. I'm happy to take questions. I do have to say that I'm not going to get into it. I have some family considerations. I have to leave in 10 minutes, so it's going to be a shorter Q&A. But happy to entertain questions. Yes?
I guess I'm interested to know that why you focused on African American white disparity, and where are the Latinos in the group, especially since you have samples from Florida and California.
Right. So there's one, so the question was why focus on African Americans relative to whites versus potentially other race ethnicities like Latinos, in which I might have states with a lot of Latinos like California and Florida. Two answers. One is that the over-reliance on the psychiatric ED occurs much more among African Americans than other race ethnicities for which we have good data. So the Hispanic help-seeking patterns for psychiatric care more closely mirrors that of whites, especially in the youth setting, okay? Now, that's not to say that cultural views of help-seeking for mental health are the same across Latinos and whites. That's not what I'm saying. There's a lot of really interesting work. Marta Alegria at Harvard, she does a lot of good work more focusing on Latinos. Bill Vega at UCLA. So that's important. The second issue is a practical one. The statewide inpatient and statewide emergency department database really have bad data on Hispanic ethnicity. So it's not, there's a data quality issue. And what question I might anticipate is, for some of these racial disparities, why did I stop at 2011? It's kind of annoying. You think usually data gets better over age, but Sid said states are decreasing their participation in this. And the quality of race ethnicity actually isn't getting better. So there's this real interesting thing, and maybe you all have come across this too. It's like, precisely at a time when society feels increasingly comfortable sharing personal information with random people on the internet, that's exactly when state agencies become more reluctant to share information for fear of privacy violation. So there's a complete change in terms of data access versus like who you'll share this talk with on Facebook like in 5 seconds, right? So it doesn't seem to be a coherence of kind of an ethical agreement. It's just out of whack for reasons that I can't explain. But that's the answer. Both interesting points, though. Yes.
So I'm very interested and curious about this sort of from the community perspective and what's really going on. One of the things that happened during this time was the increase in substance abuse and opioid use. And I wonder if that is in any way captured in these emergency room visits. It might be part of the suicide ideation stuff that's going on. And if there's a difference racially with that, which I believe there is.
Right, so the question was whether opioid use might be captured and if there's potentially some racial patterning in that for looking at suicidal ideation and self-harm, or maybe psychiatric ED visits. For the overall psychiatric ED visit classification, the federal coding scheme includes substance use disorders in that. We could argue for a long time as to whether or not we would kind of upcode that to be more inclusive or to start thinking about particular outcomes. I don't think that scholars really agree on this, but we have to be cognizant of some of the limitations of the ED data. Clinicians can code up to 25 diagnoses on SID and SED. And when you ask clinicians which one's the most important, or what's like the real reason they came in, there's not actually a rank order if you look through diagnosis 1 through 25. People have tried this. Lonnie probably spent 30 years doing this, and he said, it's hopeless. I'm not as despondent as he is. I like to think I'm eternally optimistic. But practically speaking, we just upcoded. So if anywhere in the 25 diagnoses you have substance use, that's a psychiatric condition, right? Is there race patterning to it? That's definitely worth looking into more. I have done some work on the states that collect opioid-related ED visits by month, and there's fewer than those that collected by county year. And looking in response to the Great Recession, was there changes in opioid-related emergencies following the Great Recession? That article's still under review, but I was really surprised. Actually, there's a transient drop in ED visits for opioids during the worst recession months, which completely counters the long-term effects that are well described. So if you have like economically depressed communities, over time, definitely increased opioid use, right? That's well documented. But some of the acute responses might be some inhibition, which actually isn't different than some other literature that's published but not often discussed. So acute versus long-term responses are challenging. It's definitely worth looking into more. I don't know what the priors would be. Maybe the assumption would be maybe whites would use opioids more. I'm not sure. Maybe that's the narrative we hear in some of the literature that's out there. And if there are some of you that are interested, happy to collaborate, because I'm not so much an expert in that, but I'd be happy to collaborate with someone who is excited about it. So, yes.
Great talk. Thank you.
Thank you.
I'm curious about the interpretation of more mental health visits being related to continuity of care. What do you think about another interpretation that might be unmet demand?
Right. Okay. So the question was, would more mental health visits mean continuity of care? What if it's just unmet demand? So there's two things. One is more mental health visits overall, and then there's more mental health visits per patient. We tried to kind of tease out if those are capturing different things. The coefficients were a little different, but again, it's what's really underlying this? That's a great question. I think really having a sense of, I think this is where epidemiologists really don't know what the true incidence of these conditions are across place and time. In an ideal world, we'd have that sense of incidence, and then we could say, all right, this is how many people show up, and then we see where the drop is, right? Did we completely faithfully, have that incidence reflected in help seeking? In general, we think that help seeking totally distorts what we thought of as incidence, because there's very strong racial ethnic patterns in help seeking and by SES, and barriers too, right? So it's hard to approximate that, just looking at services. But right, in terms of the demand, that's a great question. The slide that I'd like to, just thinking about that is one of the first ones I put up.
I was thinking of, there was one under the second question that made me think about that.
Yeah. Just this notion of most psychiatric epidemiologists would say that this 54% rise is not a true increase in incidence, right? There's some demand for it. And so I don't know if that's because we made it cheaper. I mean, mental health is super responsive to price. So if we expand access to it, more people use it. And I was talking to folks at lunch. It's not like a broken arm. A broken arm, if you have a broken arm, you go to the doctor no matter what the price of getting the cast is, right? If you're thinking of anxiolytics, though, price changes a little bit. Zoloft, whatever. And I'm not saying that in a facetious way. I'm just saying that it's much more sensitive over time. So it's really, I wish I had a more satisfying answer. And I think maybe unpacking CHCs a little more might help. Yes, question.
There's no obvious break in that line of ACA implementation? Or is it just hard to see on the scale? It's just
a lot of the ACA in 2014 terms. So, there's going to be. Let's see. This must have been. Maybe I plotted this before I got the 2014. Paid for the SED data are not cheap, by the way. So sorry, just to but I need to think about why I'd be happy to plot this for further years. I don't recall seeing a huge jump because of the ACA.
Because that would kind of get at your.
That's a good point.
Initial point about whether people are more likely to see all types of care.
Right. No, that's a good point. So I don't know how much that kind of price changed or the expansion related to the CHCs, but it'd be really interesting to look at that. Good suggestions. Yes.
Was there any consideration of people's perceptions where they get care? Like, for the increase in CHCs, do communities understand one versus the other and what the benefits of one versus the other would be?
You mean like CHCs versus another care modality, or CHCs versus
going
not?
To the ER? Like, how is one going to benefit me more if I want to seek mental health care?
That's a great question. So the question is, how do people perceive the quality of care delivered at CHCs or EDs, or is it same, right? That's a great point. I mean, if both are free, from the cost angle, it's no skin off their back either way, right? From a societal angle or from a perception angle, maybe they felt like they got good care, or maybe the notion is, I mean, I think the societal question about overuse of the ED might not be one that individuals have. It's kind of a systems question, not so much as a preference question. And so, so it might just be, I don't know if that means that, I mean, we wouldn't want to create more barriers to the ED, I think maybe as a society, but we want to think about really smoothing, greasing the wheels to the CHC route.
Right.
And that, in terms of on the ground work, a lot of CHCs are highly geographically localized to areas. So really just distance, travel distance is maybe the key variable. And so maybe county resolution is too broad. There is actually some zip code data on CHCs that I'm getting more recently, and starting to think about smaller catchment areas, because some of the psychiatric ED visit data is also available at the zip code. It won't be all the 9 states, it won't be all the years, but maybe that can get at more distance issues. And obviously that's a great point in terms of, I think you'd have to interview individuals about their perceptions to really get at your answer. So, good point. Yes?
What role do you feel like media plays in people seeking out help?
So the question is, what's the role of media for help seeking? I think for mental health, I think it's a big deal. When you have a very stigmatized set of conditions, where people feel in certain cultures that they couldn't come out to get care. Public service messages or having famous people tell you about their struggles with the depression, this is more just, my qualitative sense of it, not that I've analyzed it, but my feeling is that it does move the meter slowly, but in the right direction. The notion that we're really moving towards destigmatization, that's the idea. The pace of that destigmatization, I think, really varies by community, by race, ethnicity too. And so, my hope would be that we continue to move on those tracks. And I think one way too is thinking about just the system. If we don't have behavioral care integration in some way, that's like a stigma against a lot of the mental health, right? We have systems that aren't set up for integration that should be. So.
One last question, because Tim's was
Thank you.
slide.
Do you have information on number of psychiatric practitioners? Because I know in Corvallis, lots of people are recommended to go to the emergency department to get psychiatric care because there's nobody available.
That's a great point. So the information I have, I think I took from Jang Ho because he had the AHA data and the AHRQ. So or it's the HRF. So the area resource file has information at the county level of psychiatrists per capita. I don't know if anybody here represents the HRF, but I don't know if the data are amazing. I see a lot of kind of smoothing across years. So it's like they might have measured it every 5 years and said interpolate, right? That's how many psychiatrists we have. There's also this context of psychiatrists have large burnout and specializing in psychiatry is going down, right? So probably every psychiatrist you talk to would say we need more of us. But again, primary care providers are more comfortable delivering care maybe for not severe mental illness, but for some other conditions. So I think it's complicated. All I can say is I controlled for it in the analyses, but it might get at this notion of preferences, right? And so you say, oh, well, the experts in the ED, go to the ED, right? And so there's certain modalities that people habituate to because of the expertise there that maybe we could further unpack with CHCs, so. Okay, last question, then I do have to catch my flight, but thank you.
Yeah, I found it most interesting your comment about primary care, because my internship was at a primary care clinic, because it's unless they're that diagnosis code is there, I don't think it's capturing it, but I don't know how easy it is to analyze that kind of.
Right, in the CHCs, that's the thing, it's, I don't know exactly what the practices are for calling you a mental health patient or not, because if you're maybe screened for depression and you're not primarily seen for a mental health condition, maybe they consider you, diabetes or whatever else there's coded. So I feel much more confident in how we classify the ED visit than the CHC visit in terms of a psychiatric condition.
So thank you so much. It was great.
Thank you. Appreciate it.